Good morning, everyone. I would like to share with us on behalf of the team that we are working with in Kenya under a study called Jamii Bora under Kenya Medical Research Institute. And I would like to share with us some of the work that we have come up with, or some of the findings from adverse pregnancy and infant outcomes in a trial PMTCT and family health in Southwestern Kenya. Together with different affiliations that we are working with, I'll bring the findings. Okay, adverse pregnancy outcomes are a major cause of neonatal mortality and morbidity, and it affects millions of women of childbearing age. And according to WHO estimates, at least 810 women die daily as a result of preventable causes. And about 30% adverse pregnancy and infant outcomes occur in Southwestern Kenya, despite the fact that there are improved antenatal care services and improved maternity services. And our study also observed socio-cultural and financial barriers. Our study also observed socio-cultural and financial barriers, which also negatively impact access to the services. And it also examines different occurrences amongst the study participants that we enrolled in the study. So we examined severe adverse events by HIV status in a prevention of mother-to-child trial in Kenya. So Jamii Bora is a study that targets couples, that is pregnant women with their male partners. And we say it's a randomized controlled trial testing feasibility and acceptability of a home-based couple intervention. And the word Jamii Bora means, it's a Swahili word in Kenya that means a good, healthy, and thriving family. And that is the expectation of every country or every community. And so in our study, we used a ratio of 2:1 to recruit HIV-positive pregnant women, and the ratio of 2:1 was for HIV-positive pregnant women to HIV-negative pregnant women, who then introduced us to their male partners, whom we contacted and recruited in the study. And all these women are accessing ANC services at 24 health facilities in Southwestern Kenya. The women who were recruited together with their male partners were then randomized into one of the 3 study arms, namely the couple-based home visit arm, the HIV test kits for couples, and the standard care. We then analyze the severe adverse events logs to monitor any SAEs during the study period. And the study is actually ongoing, so this is done on a regular basis to analyze the SAE logs. From that point, we were able to enroll 812 women, that is by 1st December 2021, and of the 812, 544 were HIV positive, 268 HIV negative women, and of this, we managed to randomize 660 couples, as you can see. And of the 660 couples, 433 were contributed from the HIV positive wing, and the 224 contributed from the HIV negative wing. So even from that, we can see there is a deficit of 111 HIV positive ladies who are not randomized, and 21 HIV negative who are not randomized. These, we had 224 in the home visit arm, 206 in the HIV self-test kits arm, and 230 in the standard care, that is of the population. Of this number that was enrolled, we experienced 52 severe adverse events, as we can see from the bar graph. We realized the stillbirths taking the higher portion at 16, and we also had neonatal deaths at 13, with the infant deaths at 2 and maternal deaths at 1. Again, we realized that differences by HIV status, that is HIV positive versus HIV negative, were largest for neonatal deaths, that was 12 versus 1, and stillbirths at 11 versus 5. But again, even though it was noticed that HIV positive women experience any more SSEs than the HIV negative women, but the difference although more HIV positive women experience any SAEs compared to HIV negative women, that is 39 versus 13, the occurrence of any severe adverse outcomes did not differ significantly by HIV status, considering the 7.2% versus 4.9%. That is from the ratio of recruitment. So case details in the severe adverse events logs revealed that several patient and facility level factors may be related to these outcomes. And we observed different issues with patients from our community, and some of the issues were lack of regular antenatal care visits. Like in our country, it's a recommendation that at least a pregnant woman should visit the antenatal care clinic 4 times during the pregnancy. But again, we realized some did not complete their visits. And again, there was non-adherence to recommendations of ANC providers, like say, for example, if a pregnant woman maybe is advised to take an early ultrasound, maybe determine any birth defects, determine any issues that may be there, many of them were not taking them seriously. Also considering the economic situations, the socioeconomic situations of most of them in the Southwestern Kenya. There was also lack of funds for transportation to the clinic. Even though the government of Kenya already has a program, an insurance program called Linda Mama. Linda Mama is protect the woman, that is in direct translation. It's as an insurance cover that covers the pregnant woman from pregnancy to delivery and through at least the first 18 months of the baby. Still, there were issues of lack of funds for transportation of the patients to the facilities. Though the services at the facilities, most of them were still offered for free. Then we also have harmful traditional beliefs, like women who continually have to take the herbal medicine during pregnancy. Some of them have to visit some, I don't know, they said traditional healers, people who will want to do massage on the babies when they're in the womb. And I believe in the process there is still a lot of damage that is done by that. And again, there is a lot of strenuous work that the women do during pregnancy, because most of them are still breadwinners, even though they are pregnant and they are vulnerable as such. Again, we also realized facility level factors such as understaffing in most of the facilities, And again, lack of systems for prompt referral of women and infants in emergency situations. Like there was a case in our study that a neonate died out of gastrocheesis because of improper referral and even delay in referral, so that the neonate would be taken to a referral hospital for proper care. Again, there is inadequate tracing of lost to follow-up ANC women, which actually is not done in most cases, and then lack of support, psychological support. So we highly recommend, as a study, that strengthening MCH services and developing programs focused on awareness of healthy MCH practices at both community and clinic would be very important in our communities, for this would really help to reduce the adverse pregnancy and infant outcomes. And again, investment in care during pregnancy, childbirth, and the first month of life is a very serious investment that will really save many mothers and also newborns, preventing stillbirths and thus ensuring an optimal child development and lifelong health and well-being. We also recommend stakeholders' involvement to ensure that high quality of maternal and newborn healthcare is provided in all facilities, regardless of where they are situated, whether in the rural or in the urban centers. Again, most important and critical, how can we bring the couples together? How can we bring the males on board during the pregnancies? In most of our communities in the rural areas, our men receive the babies home. They don't go with the women through the pregnancy process. How the woman goes to the clinic, most of them are not even aware of. They are taken to the clinics by their friends. They get there, deliver the babies, and carry the babies back home to the men. So we recommend that couple engagement and support is very critical. Bringing or finding ways of carrying the men together during the pregnancy is very important. Thank you so much. We acknowledge the Ministry of Health of Kenya, Jamii Bora study staff, clients and families, the Kenya Medical Research Institute, University of Alabama at Birmingham. Thank you.